All right. Hello, everyone. If you're on the Eastern Standard Coast in the Eastern Standard Time Zone, it's 1:59 p.m. Hope your day is going beautifully and smoothly. And if you're not on the Eastern Standard Coast, it doesn't matter. I'm just hoping you're doing okay. Maybe you're sleeping. Maybe you're listening to this in your dreams. Hey, my name is Joey B. I do Blind Knowledge. This is the Blind Knowledge Podcast. Thanks again for joining us. We have a really special guest on that's going to be coming on in just a sec. Lynn, Dr. Yaffe, does EPR Technologies. Have you ever heard of that? Me neither, but we're going to learn a lot about it, and I think they save lives. So listen to this one, especially if you're in the medical field. I think you're going to dig it. We're going to bring them on right now. Lynn, how you doing?
I'm doing great. Nice to be with you.
I'm glad you're here. Let's get right into it. EPR Technologies, what is it?
EPR stands for Emergency Preservation and Resuscitation. It's about saving a life when standard cardiopulmonary resuscitation fails, meaning chest compressions, mouth-to-mouth breathing, defibrillation. If someone is a trauma victim and their heart stops, or sudden cardiac arrest for any reason, the paramedics or a bystander would do standard CPR if they know the techniques, and try defibrillation if there's a defibrillation nearby. And if that fails, you can try doing CPR in a person for 10, 20, 30 minutes, however long, or until the paramedics arrive. They can continue to try. But if it fails, that's it. Unfortunately, you've passed away. EPR is about one more attempt to save a life when standard cardiopulmonary resuscitation fails, by using rapid, profound hypothermia. You cool the body down, the vital organs, the body down with an ice cold flush, and you lower the body temperature to 10 degrees Celsius or 50 degrees Fahrenheit in, let's say, 10 minutes or less.
Wow, that's cold. That's super cold.
And at that cold temperature, it's not freezing, you're not frozen, and it's much colder than what they call mild hypothermia, which is only a couple of degrees below normal. Okay. But when we do profound hypothermia, at that low temperature, 10 degrees Celsius, you have no brain waves, your heart's not beating, you're not breathing, obviously, but there is still cellular life. Your cells and your vital organs are still alive. You're sort of in a temporary suspended animation, and you can stay that way. The length of time in the clinical trial that's ongoing is 3 hours. You could probably go 5 hours. But during that 3 hours, you don't have to worry about chest compressions or delivering oxygen, because you're at a very low metabolic state and your cells can stay.
Is my heart still pumping at that point?
Excuse me?
Is my heart still pumping at 50 degrees?
Your heart has stopped.
So I'm okay.
There's no cardiac function. There's no breathing. There are no brain waves. You sort of appear clinically dead. But individual cells, the cells in your brain, the cells in your heart, your liver, your kidneys, they're still alive because the temperature has been lowered. And then you're transported, surgery done, and you're resuscitated. And I can go into more of that. But let me mention that anecdotally, people have probably heard that a healthy skier might get covered in an avalanche, and then the rescuers find them in a reasonable period of time, let's say a few hours, and then they're able to resuscitate them by rapidly rewarming those people. It doesn't occur successfully all the time. I don't know how many cases there are like that during the year, but that's been reported in the medical literature. And it's because the body is cooled down so fast that oxygen and heartbeat is not needed for a short period of time, like 3 hours. Wow. It's also happened that a child might fall into a cold Great Lake in the middle of winter, and the divers find them. And because they've cooled down so quick and they didn't need oxygen and no vital functions during that, they're able to rewarm them and resuscitate them. So now we try to do the same thing in a patient who's been traumatized, maybe an automobile accident, and they've bled to the point of going into cardiac arrest, or they're a gunshot victim and they've bled to the point of going into cardiac arrest, and they've lost so much volume of blood that CPR doesn't work. Now what we want to do is deliver rapid, profound hypothermia, cool them down, and buy time for one more attempt to save the life with surgical repairs and resuscitation.
So, Lynn, let me ask you this. Let's say I'm a paramedic, right, and I'm responding to a crash that just happened on the highway. Let's say he just flew out of his car, and unfortunately CPR just isn't working for him. What does the paramedic do to actually utilize this EPR tactic?
You have to, whether it's a paramedic or as being done in the clinical trial, whether it's a trauma surgeon, the technique,
sure,
let's say, will be basically the same. And the company hopes, and I can go into it more, hopes to automate the techniques as much as possible. But the paramedic would come on the scene and would attempt CPR, obviously, standard CPR, chest compressions, mouth to mouth, using a ambu bag, to squeeze and breathe.
Mm-hmm.
They might have time, or if there are two of them, start some IV fluid, try defibrillation. But if enough volume of blood has been lost and they can't give volume fast enough, CPR fails. If the paramedic feels that that's going to be the case, they can make a judgment, and artificial intelligence is coming along soon that'll help with triage and measuring parameters. The paramedic, either before they give up on CPR or while they're doing CPR and they feel defibrillation has not worked, they must gain access to the arterial system. They have to put a large bore catheter, let's say the size of your index finger, into the arterial system.
Now, are you going PICC line?
They can do that via similar. They can do that into a femoral artery. They can do it into a carotid artery. They can do that in a large vessel in the arm.
But they got to get to the heart, basically, is what you're saying.
It's even possible, and that's what we're also able to do, is to inject a vessel, the aorta, into the descending aorta using ultrasound.
Wow. Okay.
That can be done. So, in other words, given the techniques and the ability to do that kind of ultrasound, if you can't place it in a femoral vessel, depending on the injuries, to get something into the aorta, and the heart, so to speak, so
sure,
that you can now rapidly pump in ice cold saline. This would be saline, physiological saline, salt water, in a sense, which they give IV, in the hospital.
Yeah, the bags.
Yep. But we would pump in rapidly a large amount of ice cold saline.
Ice cold. Okay.
Ice cold, 2 degree, 2 degrees Celsius.
Okay, that's pretty cold.
It's not
yes.
frozen. It's very cold. And remember, the patient is unconscious,
sure,
because of whatever injuries.
So they're not going to feel anything at this point.
They're not going to feel anything.
Okay.
So that's pumped in rapidly with a pump, and the paramedics have to carry with them sufficient cold solution. It can be 20 or 30 liters, and they can pick that up at what bay they park in.
Dry ice, you think?
Excuse me?
Would they store it in dry ice?
No, it would be on, usually the major ambulances, the major paramedics, they're able to plug their vehicle into an electrical outlet when they're parked at their station. And that can keep a refrigerator system cold on the, and the fluid cold on the paramedic. But we also have designed a small, let's say, carrying case that they can take out of the vehicle to go wherever the person, you might be in an office building or a home where the person had cardiac arrest, in order to get the fluid there. So if they decide to go ahead with EPR, They'd have everything they need to do it. Once they've cooled the patient down, well, then, of course, it's just a matter of transport. And in giving that fluid, they have to be concerned about where any residual blood goes. So we have plans for a cocoon. If they're, in someone's home, if you quickly put the patient in a cocoon, that would sort of be a bag that would collect the fluid. If they're on the street, you don't have to worry about it. If you're in a hospital setting, you don't have to worry about it. You'd be on a table that could drain the blood. If you're a sudden cardiac arrest victim and not a trauma victim that's lost blood, you have to decompress your vasculature when you give fluid, meaning you've got to put a catheter into a vein to remove blood as you pump in the ice cold saline. I don't want to pretend that these procedures are easy.
I thought it was a dream. It sounds like the most difficult thing I've ever heard, Doc.
Right, a lot will be automated.
Yeah, that's beautiful.
And decisions made with artificial intelligence for the placement of catheters, for reading the ultrasound, for measuring all the parameters during the cool down, the pump speed, the volume pressure, the temperature.
Yeah, let me ask you this. So is it just like having like a syringe kind of thing and they push down, or is it like electronic where there's like a monitor and it just kind of does its thing?
Fluid, no, you'd be connected. The catheter that is placed in the large vessel, let's say the aorta or a femoral vessel, that would be connected to a system that's adjacent to where the cool solution is kept.
Sure, and for people who don't know the aorta or any of that, we're talking about the heart.
We're talking about the heart and the large vessel that comes off of the heart.
Yes, sir.
That all the smaller vessels come off to supply your head, your arms, and your spinal cord, your liver, your kidneys.
Sure.
But the aorta is that major vessel in the chest. So we'd have essentially a pumping system that would connect to the catheter that's placed in the heart in order to flush that cold solution in very rapidly, while all the essential monitoring is going on of your brain temperature using a thermometer that's placed against the tympanic membrane in your ear, and other temperature of the body can be measured. And so brain waves, fluid pressure, temperature, everything gets monitored and assessed to make sure that the patient is at the right temperature and ready for transport. If they're already in a hospital, there will be much easier to do.
And this is happening real time, real fast, right?
This is happening real time, real fast. Right now, the clinical trial it took a number of years to get the FDA to give permission for a clinical trial. It's being done at Maryland Shock Trauma, which is a model for a trauma center in Baltimore. And there are no additives to the cold saline because the FDA only wants us to check that if you lower the temperature, you can save someone. But ultimately, there are additives that we'd like to add to the cold solution that may help to protect the brain in particular and the organs and make things easier.
I was going to ask you about that, just off the cuff. So if you're you're basically dead at that point if your heart's not beating.
Well, cellular life.
Do you start to lose like brain cells and start to lose like any kind of?
If someone doesn't have oxygen for 7 minutes, you're in trouble.
Okay, 7 minutes.
You're doing CPR. If you need CPR, if there's no heart function, 7 minutes is probably as long as you can really go.
So this is all happening before 7 minutes, is what you're saying?
Well, CPR is being done, and maybe CPR is being done for 10 minutes, and then you're set up to do EPR. You want to continue doing CPR until you start that cold flush. You don't want to stop CPR and then sort of put your catheter in and waste time. So, you're continuing CPR. Hopefully there are two paramedics, and one is continuing CPR and breathing, and the other is getting set up for EPR, getting the catheter in appropriately, and then you do the rapid cold flush. And once you get down to target temperature, you're not losing any brain cells for 3+ hours. This has been done in pigs and large animals. The pigs are very intelligent. You can train
I've
them.
heard that, yeah.
And they're under anesthesia. The animals can get surgical trauma, and then they're allowed to bleed out to the point of going to cardiac arrest. A few minutes they wait, then they do CPR on them, and then they do EPR, and then they recover the pigs, after 3+ hours, and they remember what they were trained to do. And when the pigs are autopsied, the organs look normal. So
you've tested this on pigs. You've tested it on, I'm sure, other animals at this point.
Small animals, yes.
Are you in clinical trials at this point?
Yes, the clinical trials have started at Maryland Shock Trauma, and it's very slow to do the clinical trials, meaning you don't see a patient that fits the bill protocol that's approved by the FDA.
Oh yeah, they must have to be a checklist that they meet.
So in other words, a patient who gets EPR now, they can only go into cardiac arrest after they arrive at the trauma center. If you go into cardiac arrest in the ambulance and the paramedics do CPR while one is driving you to the trauma center, you're not a candidate for the clinical trial. They want to know when time 0 is, when you go into cardiac arrest. And then
so they want all this data, basically, is the reason for that, right?
Exactly. Yeah. And then you have to be fortunate enough to be there when the trained EPR trauma team is on call.
Oh, sure, because they have to be specially trained to do this, of course.
There's only one team now that's trained to do it at Maryland Shock Trauma, the only place in the world where this is being done.
The leaders.
Yeah,
right on.
So you have to, that's why it takes time to do the clinical trial.
How long have you guys been in these clinical trials at this point?
It's been, during the COVID pandemic, the clinical trial was put on pause, and they've only are restarting now. The reason it was put on pause is because many of the patients who are hospitalized with COVID had respiratory problems, lung problems, and they were put on what's called ECMO, extracorporeal membrane oxygenation, where they would have a machine breathing for you, and they would have to circulate your blood through that. And so it would require some blood bank blood.
Believe it or not, I have heard of that. Shout out to my mom if you're watching. Respiratory therapist, one of the best in the world.
So the availability of blood put EPR on pause.
Right on.
I'd like to, if I can, say a little bit about the historical reasons that this is being done.
Yeah, please do.
In the in the late 1950s, 1956 is, I think is the date, Dr. Peter Saffer, who was at the University of Pittsburgh, he was an anesthesiologist at Pittsburgh, but before he got to Pittsburgh, he was at Johns Hopkins, and he invented mouth-to-mouth resuscitation. Before that, there wasn't adequate breathing in doing, CPR wasn't really done. They attempted some crazy things with raising your arms to try and inflate your lungs. It didn't work. No one was effectively doing chest compressions. And Dr. Saffer and one of his associates, they invented mouth-to-mouth, showed that it worked, combined it with effective chest compressions. And Dr. Saffer wrote the book called The ABCs of Resuscitation, which was the model of how to do it. And when he had done that, then in the that was the end of the 50s.
That's incredible. Just to want to just articulate real quick on that. That's incredible. So you're saying CPR has only been around since the 50s or 60s. That's amazing if you think about that.
Well, the first defibrillator was only really practically used in like 1947, 1948.
Wow.
And there wasn't, really effective CPR. But Dr. Saffer, he was at Pittsburgh now after doing this and putting the book. He formed the first team of paramedics. He took a group of African Americans, orderlies, and some other African Americans that he made contact with in Pittsburgh, and he trained them to be the first paramedics, really the first full capable paramedics in the world that now were effectively doing CPR and defibrillating patients. And he called it Freedom House. And in the early 60s, of course, racial discrimination, it was before 911 was a call. If you had a medical emergency, you called the police.
Wow.
And white ambulance drivers didn't like to go into black neighborhoods in Pittsburgh and probably in many other cities. So Dr. Saffer formed the first paramedics, who were all African American, called Freedom House. If you look this up on Google or YouTube, you can see the history of Freedom House. Dr. Saffer was an amazing man. And then in the early 60s, 911 was started. And Dr. Saffer was key in integrating that with his paramedic team. And then many of those paramedics, they went to other cities to form paramedic units there. And one of Dr. Saffer's proteges who helped him train Freedom House was Nancy Caroline. And she went to Israel to start the paramedic service in Israel. In Israel, she's dead now, considered the mother of paramedics in Israel. Dr. Saffer died in 2003, and I worked with him from 1995 until 2003.
Wow.
And myself and two other individuals who worked with Dr. Saffer, we formed EPR when the time was right for that. So Dr. Saffer was really instrumental in all of this. And the reason he came up with the idea to do EPR was because the military, if you look back historically over Vietnam War, Iraq, Afghanistan, 80% of combat casualties, American casualties, dies from massive bleeding. And they go into cardiac arrest. It's called exsanguination cardiac arrest. The other 20% die from severe head injuries or their bodies are blown apart. But the military said, well, we can't give enough blood fast enough to save those 80% who die from rapid bleeding.
Yeah, that blood's coming out. Yeah.
So Dr. Saffer said, what about rapid profound hypothermia? In the early days, he called it suspended animation. In the medical literature, it's called suspended animation, but we changed it to EPR. It's like CPR fails, then EPR, CPR, EPR.
Suspended animation. So that's what? Can you define that just so people know?
Well, I mean, it's a science fiction term. That's why we don't usually use it.
It feels kind of Star Trek-y.
But it really means, in a sense, lowering the body's metabolism to the point that it's just enough to keep your cells alive. If you can lower the metabolism to almost zero, you don't need much oxygen for those cells to stay alive. So that's why it's called, you suspend the animation.
It's a very low sense of, or very low consciousness,
you're not in
basically.
any sense, dead.
Yeah.
You just lowered the metabolism to a point.
Low and slow.
Yeah, it's sort of like, let's say, hibernating bears. Their metabolism is lowered, and that's why their heart rate is slowed. Their respirations are slowed. It's not like ultra profound hypothermia, but it's like a metabolism getting close to sort of a suspended animation.
Lynn, let me ask you.
You would do that for three hours, maybe 5 hours maximum.
That's good to know. This is really interesting stuff, by the way. Thank you, everyone, for joining in. Thank you for the, I'm getting some messages through my email. This is the Blind Knowledge Podcast. I am here with Dr. Yaffe? Is that how I pronounce it? Yaffe, I'm sorry, Dr. Lynn Yaffe, EPR Technologies, talking about all things medically wacky at this point. It's a fascinating conversation. I do appreciate the time. If anyone has any questions or just wants to get in on the action, throw it in the chat, or you can text us at 877-237-1143. Just off the wall question, what if someone was breathing and they didn't need CPR and they were injected with this frozen saline? What would happen?
Well, after you lower the body temperature for 2 to 3 degrees, your heart stops.
Okay.
So if your heart stops,
so bad idea.
You're not breathing.
Sure.
If you don't have any artificial respiration, once your heart stops, essentially you'll be dead in 7 minutes or so, unless you cool the body down to profound hypothermia. So you've got to make the choice there, so to speak.
So who was the one to figure out that if you do all of these steps, you can save a life?
Well, Dr. Saffer at the lab in Pittsburgh, when at the time I was in the military, when I met Dr. Saffer before I started working with him. But really the taxpayers, the U.S. taxpayers, through Army and Navy grants, funded this research in the late 1995, okay. Even beyond Dr. Saffer's death in 2003. And it was done in small animals, and I mentioned pigs. And so it was demonstrated that this could be done successfully in animals. You show that work that was all published in the literature. You show that work to the FDA, that it can be done in small and large animals. And there's that anecdotal evidence about skiers that I mentioned. So the FDA took a very long look at it. They wanted to know exactly, which patients this would be done in, under what conditions. And, and then we sort of and then we had to train the teams and whatnot. And then the COVID happened, and now they're starting up again. So, I think it'll take another 6 to 8 months, to do the clinical trial. In one sense, it's not like you say, oh, here's a cancer patient. I hope this clinical trial, they can use it on a cancer patient and all works. We have to sort of sit on the sidelines at Maryland Shock Trauma, and they're waiting for an unfortunate trauma victim, from even an automobile accident or a gunshot wound.
So they're waiting for a specific circumstance in order
to be in the right age group, meaning they're not going to do this.
I was going to ask. I was going to ask you that.
Minor. You have to have no evidence of head injury.
Okay.
At the time. Go ahead.
Yeah, male, female, young, old, races. Does any of that matter?
No, that doesn't matter.
Okay.
They obviously they're not going to do it on a pregnant female, but a female, and let's say middle age, 18 or older, under 65, who has no evidence of head trauma.
Now, why is that?
Well, they don't want to. The goal is to show that rapid, profound hypothermia can save a life when CPR fails.
That's the main premise. That's what we're trying to do here.
So we don't want to complicate that by some head injury that may compromise the procedures, so to speak. So obviously, if they could read the person's medical record in advance, there might be other things you'd eliminate. But you don't have that luxury. If someone's on, I don't know, if someone has seizures or some
like epilepsy or something,
disease that could conceivably complicate things.
ALS.
And, right. And so ultimately, when the clinical trial is completed, the FDA may say, oh, this looks very good. Let's do the clinical trial, another clinical trial at 5 trauma centers.
Okay.
And they might say, okay, this looks so good. train several paramedic teams to do this.
So there's steps to this process, basically.
Yes, there are various steps like anything. I mean, clinical trials, phase 1, phase 2, phase 3.
Am I going to read about this in the New England Journal of Medicine? Is this where I'd hear about it?
Eventually, I mean, so much has been published about this. With a successful clinical trial, the FDA likes to keep a lid on things until they look at the data. But
I don't know. I did my research, and there's a lot on EPR, and it's pretty fascinating stuff for sure.
There's a lot on it, no question about it. But it's hard to predict what the FDA will do with a successful clinical trial. Many trauma centers across the U.S. are anxious to do this because it's one more chance to save a life.
And that's what it's all about. And let me ask you something, Doc. I got to know. So let's say it all goes well with the FDA, and let's say they actually approve it. What are the best places and methods and like circumstances, I should say, or situations where this can be used? Is it the paramedic? Is it the trauma unit? Or is it all of the above?
It's ultimately all of the above.
Wow.
I think the FDA first off would say, okay, do this at trauma centers.
Yeah.
And then maybe they'll broaden it out to emergency rooms, and then maybe hospital floors.
Yeah, that makes sense.
But I think relatively early on, they would say, okay, let's explore how we're going to have paramedics do this. Let's look at training some paramedic teams and what equipment they're going to use, and how are you going to provide, the necessary decision support and communication, and
because that's who I think of. That's who I think of that could really utilize that as like a car crash or
be a separate, review of the FDA reviewing how paramedics are doing that. And ultimately, if everything is approved, obviously paramedics will have to be certified and get special training to do this. The company's working on, what would be required to do that through simulation training, or working for a while with the team that's already doing it.
Yeah, almost like getting a CPR certification, right?
It's also interesting when I mentioned simulation, it just crossed my mind that Dr. Saffer, who started mouth to mouth and integrated with chest compressions and then EPR, he and a doll maker in Europe named Laerdal, they made the first simulation doll for practicing CPR.
Oh, wow.
Called Resuscitate. You can look that up on YouTube. The history of Resuscitate, which was really the first simulation doll. Now they have other ones, different sizes, but the face of Resuscitate was the death mask of a young woman who jumped into the Seine and committed suicide. And
Lord.
Her death mask they used for the first Resuscitate. So I think it's on YouTube. There's
everyone go check that out immediately.
This Resuscitate is the most kissed woman in the world. Mouth-to-mouth resuscitation.
That's awesome.
A lot of interesting historical stuff.
Go, Annie, go.
And Dr. Saffer wrote an autobiography, which is now available online at the American Society of Anesthesiology, the Museum of Anesthesiology. Important anesthesiologists, they've asked a few to write their autobiographies.
Okay.
And so that's an interesting. It's got a lot of pictures in it.
What was his first name?
His first name was Peter.
Peter.
T-E-R, and his last name S-A-F-A-R. He was a Viennese during World War II. He was over in Germany.
Yeah, Austrian.
And I think he did some work as a medical orderly back then. He was a young man. And then
Yale.
He came to the U.S. to do his medical training.
Wow.
And he was at Yale, Hopkins. And he was nominated for the Nobel Prize at least 3 times. He never received it, but I mean, it's sort of an honor just to be nominated.
People like this fall through the cracks in history. I think this is a really interesting person. I'm going to go ahead and throw this on the ticker for everyone that's interested, because this guy, he invented freaking CPR. That's amazing. And not only that, he's a doctor, and he's saving lives, and he looks like a genius. So
right. He was very, very smart. Died in 2003, and also just in that scroll it said is a pioneer in critical care. He started the subspecialty of critical care medicine.
Unreal.
It wasn't the subspecialty until he designed the first paramedic ambulance, really, because before that they were just ambulance drivers. They didn't do anything. So he's got did a lot of interesting things, starting paramedics, first ambulance, resuscitation. Really started the subspecialty of disaster medicine too.
It says here's a PMC NCBI. I wonder what that is.
Huh. PMC.
Yeah, PMC. I have no idea. That might not have anything to do with anything. It just says the National Library of Medicine. It says he's a PMC. Public Med Central. It's the name of the site. Sorry, Doc.
Oh, okay.
Wow. Okay, so this is really interesting.
Very interesting fellow.
When do you?
They
yeah, go ahead.
When he was at Pittsburgh doing all of this work, it was called the International Center for Resuscitation Research, and then when he became professor emeritus, they named it the Saffer Center for Resuscitation Research. So. Oh. They named it, and he insisted that his wife be included. So it's the Peter and Eva Saffer Center for Resuscitation Research, but it's usually just referred to as the Saffer Center. And his wife is still alive. I think she lives in Oregon now, where her children and grandchildren are located.
Shout out to her, and that's incredible. I'm going to definitely read up on that myself. Again, guys, Peter Saffer, Safar. Any questions for the doc? Let me know, 877-237-1143, or drop it in the chat. Send a smoke signal, send a postcard. We can get your answers right now here on the Blind Knowledge Podcast. What else should people know about this technology?
EPR? I haven't mentioned that after someone is cooled down to profound temperatures by EPR, and they're either transported to the hospital or they were in the hospital, and they're taken to surgery for surgery to be done while they're still at that 10 degrees Celsius, surgical repairs are done if they had a gunshot wound or a traumatic event. And then they're put on, after the surgery is done, they're put on cardiopulmonary bypass machine. And now they're given blood bank blood back, let's say universal blood if they weren't typed.
What's that, type O negative?
Yeah. And then that blood bank blood is pumped into them, and the saline that cooled them down is drained away, so
okay.
And you give them blood back, and then
so that's how you get the saline out, basically.
Right. Yeah, and you give them blood back. And okay. And then and that's existing technology, a cardiopulmonary bypass machine. Sometimes that's frequently used for open heart surgery when they have to stop the heart from beating. So they're put on an external heart, so to speak, which is on cardiopulmonary bypass, pumps blood and breathes for the patient. Sometimes that's done on neurovascular surgery too, where they'll lower the patient's temperature a little bit, not down to profound temperatures, but so then. And
let's not get it mixed up. Just want to iterate. Sorry to cut you off. These are miracles that these technologies even exist. Well, we're saving lives here. This is the real deal.
Yeah, I think many things in medicine are miracles.
Scientific miracles, of course.
Yes. Absolutely, scientific miracles. I mean, the things they're doing with cancer therapy and anti-aging. I don't know if you've been. I don't want to go off on another topic, but there's recently been reports about the Holy Grail for cancer therapy. What has to do with interrupting the proliferation cell nuclear antigen, which is abnormal in cancer cells, and to
Wow.
agents that bind to that, which essentially kill cancer cells but not kill normal cells. I think they're hoping to start a clinical trial soon, but that could be, in the articles they call it the holy grail
That's amazing.
for cancer. And then anti-aging research. I mean, that is moving along.
Well, these billionaires don't want to die, so they're all trying to stay alive forever. That's what I heard.
But even more dramatic techniques in anti-aging. There's what's called the naked. What's it called? The naked vole. It's a rodent in Africa, and it's almost hairless, and it's very similar to, let's say, a rat, but it lives 30 times longer than a rat, because it has DNA repair enzymes, which are more potent, and many, many copies of that in their DNA. Now, some of those advantages they've genetically transferred to mice, and they're studying if the mice it looks like will live longer.
So when you say anti-aging, we're not talking about just skincare. We're talking about the whole body.
Whole body.
Wow.
And we're not talking about necessarily taking someone who's 90 and turning them into a 40-year-old. I don't think that's going to be done. Some people talk about that.
Imagine.
And reprogramming cells to be young again, in a petri dish. They do things like that. But I think most anti-aging would be directed at slowing the aging process so that you naturally, through genetic manipulations, just slow the aging process. So maybe you'll live to be 200 years. I mean,
so basically the body would heal better, it wouldn't experience so much trauma.
It wouldn't age. What is aging? People think it's the accumulation of genetic changes, of the inability to make perfect proteins. People think your transcription RNA is involved. And so it's a general decrease and accumulation of errors, so to speak. I mean, I don't pretend to be an expert in anti-aging. You should look for someone to come on to talk about that. But boy,
absolutely will. Yeah,
be a newborn baby, because I think you'd live a very long time.
Yeah, that's amazing technology. I mean, where do you find your information like that? Where do you read about that?
I mean, I look at go online and look at a number of journals. Anyone can go to PubMed, which is the Library of Medicine site. If you just look up PubMed, then you can type in any word, or group of words, and it gives you a list of the journals, and you can restrict it to journals published in 2022, 2023. And so you could type in anti-aging, and you might get very complicated articles to read. Or you can go to the more general sites like Science Daily.
Love Science Daily.
There's some great sites that keep up on important medical advances.
It's very interesting. And is this the best place for people to read about EPR Technologies, EPR-technology.com?
Technology, or EPR Technologies, plural, singular, or technologies. They both go to the same place.
Okay. All right. Perfect. Because people should definitely read up on this if they're interested.
There are a lot of videos and a lot of information. Our lead trauma surgeon, Sam Tischerman at Maryland Shock Trauma, he did a TED Talk in the past, which is interesting. He gives some details. He was invited to do a TED Talk, which was very nice. I've done a few other podcasts, which are up on YouTube. If you type in my name or EPR Technologies, that'll come up on YouTube. If you want history, type in Peter Saffer or Freedom House or Suspended Animation. There's a lot of interesting stuff on YouTube. Absolutely.
That's amazing. That's amazing stuff. We're talking about life-saving technology that could be the next step after when CPR doesn't quite cut it. EPR may be able to just jump in there. That saline solution can cool down the body to almost a comatose temperature and save a life. Hopefully within 7 minutes, Doc. Right?
And exactly. And if anyone has any questions, when this podcast is over, on the website that you showed the address, there's the ability to email me and to make comments or
Perfect.
For any information.
Perfect. All right, Lynn. That was amazing. Thank you so much for coming on and teaching us all about this. And you.
Thank you. I enjoyed it very much. Great fun.
I appreciate it. Thank you so much.
Once our clinical trial is successful, maybe you'll have me back.
For part 2, for sure. For sure. All right. Thanks, Lynn. Have a good one, buddy.
Okay, you too.
Wow. EPR Technologies. Go check it out. EPR-technology.com. Dr. Lynn Yaffe. Really, really interesting stuff. Life-saving technology. Life-saving stuff. If CPR isn't working, we're going to freeze them. Just not frozen, but we're going to put them in almost an automation kind of thing, and hopefully, they hang on. So it's a beautiful thing. Hopefully it goes through the FDA trials. I'm not a doctor, but he is, and it was really cool to have him on. Who am I? I'm just a podcaster. My name is Joey B. This is the Blind Knowledge Podcast. You guys are awesome. We will check you next time. Ta-ta. Be safe. And hey, if you didn't tell someone you love them today, go do that for sure.